Welcome to the deep dive, everyone. Today we're diving into something super relevant, I think, for a lot of folks out there. The world of asthma and COPD pharmacology.
Oh, yeah, definitely. It's
And to guide us through this, we've got the notes from a presentation by Dr. Khaled Hasan, who's a professor of clinical pharmacology.
right. And he had some really, really good points, I think, that are going to help us connect all the dots.
Yeah, definitely. He does a great job of sort of painting the bigger picture, which is what we're all about here, right? Not just understanding these drugs in isolation, but seeing how they fit into like the whole management strategy.
Exactly, yeah.
So one of the things that really struck me from the get-go was Dr. Hassan's emphasis on the difference between asthma and COPD. You know, I think sometimes we just kind of lump them together as breathing problems, but he made it clear that understanding that distinction is like crucial for treatment.
Yeah, and I think it's easy to do that, right?
Yeah.
Because they both involve airway obstruction and all that.
Right.
But that key difference, like you said, is reversibility.
Yeah.
Asthma, in theory, you can reverse it, but COPD, not so much.
Right. And I think that really sets the stage for everything else we're going to talk about today because it informs like which medications we use, how we approach management.
Absolutely.
Well,
it makes you think about the severity of it, too, right?
Definitely. And speaking of severity, I don't know about you, but that statistic he threw out about COPD being the fourth leading cause of death in the U.S., that really hit me.
Oh, for sure. It puts it all into perspective, doesn't it?
It does. It's like, okay, this isn't just a minor inconvenience. This is a serious, public health issue.
Yeah, definitely.
So let's dive into some of those nitty-gritty details. I always find visuals helpful, and Dr. Hasan had some great ones showing what's actually happening in our airways when we're talking about these conditions.
Yeah, the visuals are key.
So with asthma, he talked about those mast cells, those little alarm bells in our airways going off when they encounter an allergen.
Yeah, it's like a chain reaction almost.
Right. It's like they're sending out these SOS signals and releasing all these inflammatory chemicals.
And then you get bronchoconstriction.
Right.
The airways just clamp down, making it hard to breathe.
Right. And then to make matters worse, you've got that mucus production ramping up, clogging things up even more.
Oh, yeah. It's a mess down there.
It is.
Okay.
But in COPD, it's not just a temporary traffic jam. Like in asthma, we're talking about actual damage happening over time, right?
Exactly. It's more like, it's like those airways are undergoing renovations that you don't want. You know what I mean?
Yeah, like some unwanted remodeling going on.
The walls thicken. They become less flexible.
Right. So it's like the road itself is getting narrower and bumpier.
Yeah, exactly.
And no wonder breathing becomes such a struggle.
Yeah.
And that brings us to the world of pharmacology, where we're essentially trying to manage that traffic flow, maybe even do some road repair.
Right. Exactly. We've got our toolbox ready to go.
So let's start with the rescue inhalers. I think most people have heard of albuterol.
Oh, yeah, for sure.
But understanding how it works at a cellular level is pretty amazing. It's like this little molecule with a very specific job.
Yeah, it's like a key fitting into a lock, right?
Yeah.
It binds to those beta-2 receptors on the smooth muscle cells surrounding the airways, and boom, they relax.
It's like releasing a clenched fist, letting the air flow freely again.
Exactly.
But I know there are also long-acting beta-2 agonists, salmeterol, formoterol.
Right.
They work a bit differently, right?
Yeah. Think of it as more of a sustained effect. They help to keep the airways open for longer, preventing those spasms from happening in the first place.
So for someone with, say, persistent asthma, these long-acting agents would be part of their daily routine, whereas albuterol is more for those SOS moments.
Yeah, exactly. It's about managing both the immediate symptoms and kind of like preventing future ones, you know?
Right. It's a two-pronged approach. Which leads us to another important class of medications, the muscarinic antagonists.
Yes.
Like ipratropium and tiotropium. Now, I remember from Dr. Hasan's presentation that these work by blocking the effects of acetylcholine, which is a neurotransmitter.
Right. Acetylcholine usually acts as a brake on the airways, so these medications essentially release that brake.
So it's another way to keep those airways open, but through a different mechanism.
Exactly. Different pathways, same goal.
And then we've got the big guns, the corticosteroids.
Yes, the heavy hitters.
These are powerful anti-inflammatories, and we've got both inhaled versions like beclomethasone and fluticasone, and then the systemic ones like prednisone.
Right. And Dr. Hasan really emphasized that distinction because the systemic ones come with more baggage, right?
Yeah, those side effects are no joke. That's why he was so adamant about proper inhaler technique, getting that medication right where it's needed and minimizing those systemic effects.
Absolutely. It's not just about taking the medication, it's about taking it correctly.
Right. It's about being an empowered patient. Now, Given all these different drug classes, it's clear that treating asthma and COPD isn't one size fits all,
Oh, definitely not. It's all about tailoring treatment to the individual.
which is where those flow charts and algorithms come in, right? Dr. Hassan had some excellent visuals showing that stepwise approach to treatment.
Yeah, those were good. Like starting with a simple bronchodilator for mild cases, then stepping up to combination therapy if needed.
Right. So someone with mild intermittent asthma might just need a rescue inhaler, but someone with more persistent symptoms might need a daily inhaled corticosteroid plus a rescue inhaler as needed.
Exactly. It's about finding that sweet spot, the right medication at the right dose for the right patient.
And that's where staying current with the guidelines comes in. Dr. Hassan really emphasized the 2023 GOAL-LD guidelines for COPD
Oh, yeah. Those are key.
as a major update in how we approach treatment.
And not just for healthcare providers, right?
Mm-hmm.
Patients can benefit from understanding these guidelines too.
Absolutely. It's about empowering everyone involved. Now, I think it would be helpful to see how these guidelines play out in a real-world scenario. And luckily, Dr. Hassan gave us a great case study, a patient named J.K.
Ah, yes, JK. He was a great example of how those spirometry numbers and algorithms translate into actual patient care.
Right. So shall we meet J.K. and see what his story teaches us?
Let's do it. So JK, longtime smoker.
80 pack years,
Yeah, 80 pack years.
which is, a pack a day for 80 years. That's a lot of exposure to those irritants.
Lot of damage potential there.
And he had cut back recently, I think, to like 1.5 packs a day, but he was already starting to feel it, the shortness of breath, especially with exertion.
Even at rest sometimes, he said.
Wow. So it was getting pretty noticeable. And his spirometry, if I remember correctly, wasn't painting a very pretty picture either.
No, not really. His FEV1 was 74% of predicted.
Which, for those who don't speak spirometry, basically means his lungs weren't emptying as well as they should.
Right. Airflow obstruction, basically.
And his FEV1 FEC ratio was 66%.
Yep, below that normal range, which,
Huh.
helps us distinguish COPD from other lung issues.
Right, right. But Dr. Hassan was also really big on not just focusing on the numbers, but also considering the patient's experience, right? How those symptoms are actually impacting their life.
Oh, yeah, for sure. Gotta look at the whole picture.
So they used the COPD assessment test, the CAT, to gauge that impact. And if I recall, JK scored a 13.
13, yeah. Moderate impact, so not just the breathing troubles, but probably fatigue, coughing, all that.
It all adds up, doesn't it? So we've got JK, significant smoking history, noticeable COPD symptoms, spirometry showing moderate airflow obstruction. Where does that put him in those Gold D categories?
Well, based on that FEV1, he's Gold deal grade 2 moderate obstruction.
Okay, Gold D too.
And then factoring in those symptoms and the CCAT score, his risk category would be Gold EB.
Gold D2, risk B.
Got it.
So now we pull out those treatment algorithms.
Exactly. Time to put those guidelines into action.
And for someone like JK, what did Dr. Hassan recommend?
The guidelines suggest starting with a single long-acting bronchodilator.
So either a LABA or a LAMA.
Right. Salmeterol, formoterol, tiotropium, the usual suspects.
And the choice between the two would depend on individual factors, right?
Yeah.
Side effects, cost, all that.
Exactly. Personalized medicine.
But what if that's not enough? What if JK still isn't getting good relief?
Then we step it up. Combination therapy, usually a LABA and a LAMA.
Double the bronchodilation.
Exactly. It's all about finding that right balance for each person.
JK's case is a great example of how those algorithms really work in practice. It's not just memorizing drug names, it's understanding how to apply that knowledge.
Right. Putting it all together.
Now, I'm curious about some of the less common treatments Dr. Hasan mentioned. Azithromycin, for one, an antibiotic with anti-inflammatory effects.
That one always throws people off. An antibiotic for COPD.
Right. But apparently it can help prevent those exacerbations.
Some evidence for it, but more research is needed.
Not a magic bullet, but definitely intriguing.
For sure. And then there's roflumilast daliresp.
Ah, yes. That one works a bit differently than the bronchodilators, right?
Yeah, it's a phosphodiesterase 4 inhibitor.
Catchy name.
It basically blocks an enzyme involved in inflammation. More of an add-on therapy for severe cases.
So another tool in the toolbox, especially for those tough-to-treat folks.
Exactly. And then we can't forget about the monoclonal antibodies.
Oh, yeah, those are everywhere these days.
Seems like there's one for everything.
But they're expensive, and they come with their own set of side effects.
Definitely not a first-line option, but for those who aren't responding to other treatments, they can be a game changer.
It's fascinating how much research is happening in this field. Always something new on the horizon.
Keeps us on our toes.
It does. So we've gone from the cellular level all the way up to these cutting-edge therapies. It's been quite a journey.
A whirlwind tour of respiratory pharmacology.
And I think what's most important is that our listeners feel empowered to take this information and use it.
Absolutely. To advocate for themselves, to ask questions, to be active participants in their own care.
Well said. And remember, Dr. Hasan's notes had tons of resources, links to the Goldie guidelines, articles, all that.
So if you're feeling curious, keep digging.
Curiosity is key. Now, before we wrap up completely, I want to shift gears a bit and talk about something that might seem simple, but is actually quite complex: the cough.
Ah, yes, the cough, that trusty respiratory reflex.
It can be a minor annoyance or a sign of something serious.
And it certainly keeps us busy in the respiratory world.
That it does. So let's dive into that cough puzzle and see what pieces we can uncover. So coughs, we all get them, but Dr. Hasan's presentation really made me realize how much we take them for granted.
Oh, for sure. It's like one of those things you don't think about until it's driving you crazy, right?
Exactly. And it can really impact your life, the sleep, the fatigue, even, social situations, depending on how prominent your cough is.
Oh, yeah, absolutely. But before we even get to treating the cough, Dr. Hasan was really adamant about figuring out the cause, right? It's like you wouldn't just slap a bandage on a warning light in your car.
Right, you got to figure out what's triggering it.
Exactly. So, first things first, acute versus chronic. Acute coughs, less than 3 weeks, usually due to colds or the flu. They tend to resolve on their own.
But it's those chronic coughs, 8 weeks or more, those are the ones that send up the red flags.
Exactly. And there are so many potential culprits: allergies, asthma, even GERD, believe it or not.
GERD, the heartburn thing?
Yep. Stomach acid backing up into the esophagus can trigger a cough reflex.
Wow. The body is so interconnected, isn't it?
It is. So that medical history is crucial: exposures, past conditions, medications, smoking history, all of it.
Right, because smoking itself can irritate the airways and make you more prone to coughs in general.
Absolutely. But sometimes, even after you treat the underlying issue, the cough lingers.
Like a phantom cough.
Exactly. Dr.
Right.
Hasan called it a post-infectious cough. It's like those cough receptors are still on high alert even after the trigger's gone.
Okay, so how do we approach that?
Well, in those cases, the focus shifts to suppressing the cough itself.
So cough suppressants.
Right. And antitussives. And there are two main types: centrally acting and peripherally acting.
Okay, break those down for me.
So centrally acting ones, like codeine and dextromethorphan, they work directly on the cough center in the brain.
So they're basically telling your brain to chill out and ignore those signals coming from the airways.
Pretty much. But then you've got the peripherally acting ones, which work more locally, like at those cough receptors themselves.
Interesting, but what about those coughs that bring up phlegm? The productive coughs.
Ah, yes. We don't want to suppress those completely.
Right, because coughing up that mucus is actually a good thing.
Exactly. So we might use expectorants, things like guaifenesin, to thin the mucus, making it easier to cough up.
So it's all about matching the right treatment to the type of cough.
Exactly. It's a puzzle, and sometimes you need a healthcare provider to help you solve it.
Couldn't agree more. We've covered so much ground in this deep dive, from those tiny mast cells to the complexities of cough management.
It's been quite a journey through the respiratory system.
It has. And I think the biggest takeaway is that knowledge is power. The more we understand about these conditions, the better equipped we are to advocate for ourselves and our loved ones.
Absolutely. Don't be afraid to ask questions, to do your research, to be an active participant in your healthcare.
Couldn't have said it better myself. A huge thank you to Dr. Hasan for his insightful presentation, and to all of you for joining us on this deep dive.
Okay.
Keep those minds curious and those airways open.